Welcome back to the Rebel Core Content Podcast. This is Swami, and today we have something a little bit different. We're going to dive into a critical piece of legislation passed in 1986 in the US, the Emergency Medical Treatment and Active Labor Act, or EMTALA. And I know we have a lot of international listeners, and this topic is going to be very specific to the US in a lot of ways, but it is particularly important right now. And so we have to get into this issue. I'm not alone for this discussion because I'll be honest with you, this is not my forte. Policy and these laws are not really what I have specialized myself in. So I'm here with two emergency physicians. I've got Dr. Dara Kass, Dr. Monica Saxena. Welcome to Rebel. Can you guys give a little bit of background as to who you are before we dive in?
Sure. So I am Dara Kass. I'm an emergency physician in New York. I have done a few things in my time. I started an organization called FemIM. I recently worked for the federal government as a regional director at the U.S. Department of Health and Human Services. And I am now back to practicing clinical emergency medicine while working to talk a lot about the situation on reproductive health care, specifically for our emergency patients.
And I'm Monica Saxena. I am an assistant professor at Stanford University School of Medicine, and I'm also a practicing emergency medicine physician at Stanford Department of Emergency Medicine. Most of my research focuses on access to care, reproductive justice, and prior to coming to medicine, I was a human rights lawyer. So I come to all the discussions with that perspective.
Excellent. All right, so let's dive in. Let's go really basic to start. What is EMTALA?
EMTALA is a law that was passed in 1986 that is the Emergency Medical Treatment and Labor Act. And I want to include the and labor because that's going to come in a little bit into the case that's in front of the Supreme Court. It ensures that public access to emergency services are delivered regardless of the ability to pay. It was invoked with the Social Security Act. So Section 1867 of the Social Security Act imposes specific obligations on Medicare participating hospitals that offer emergency services to provide a medical screening exam when a request is made for examination or treatment for an emergency medical condition, including active labor, regardless of the ability to pay. And then hospitals are required to provide stabilizing treatment for patients with emergency medical conditions. If a hospital cannot stabilize the patient within its capability, or if the patient requests, an appropriate transfer can be implemented. And I want to take a pause for a second to say that was from the CMS website, the Center for Medicare and Medicaid Services. It is how the law was written and how it's communicated to the general public. But we are different, right? We are the people that live under EMTALA. And one of the reasons we're talking about this is that there is a Supreme Court case right now that's going to be heard in the general public by all Americans about EMTALA. So I want to reiterate, what does the EMTALA law mean for us, right? Well, it means that everybody who presents to our ER must be screened for an emergency medical condition or get a medical screening exam by a qualified medical personnel. We're used to that, right? This is why we have a lot of doctors in triage. It's the reason that we talk about MSc exams on our initial exams. We've seen this in practice almost every day in our ERs. And EMTALA applies until the medical screening exam clears the patient for an emergency medical condition or the patient stabilized or transferred. You have to provide stabilizing treatment within the capacity of your medical facility before you discharge the patient. You cannot delay the examination or treatment regardless of the patient's ability to pay or insurance status. And again, these are the things that we take for granted sometimes, but they will come into play as people challenge the protections that are the patient protections that exist under EMTALA. And there are 4 requirements for an appropriate transfer. And again, we reiterate this. I think we need to talk about it now because we're talking about a world in which care for patients isn't uniform across hospitals, not just because of ruralization or resource utilization, but now because of these changes in access to care from legislation, which is something we haven't ever seen before. And so when you consider transferring, 4 conditions have to be met. The transfer has to minimize medical risks to the patient, which has been thought about in things like if somebody's in active labor, right? They have to be able to complete the transfer before they deliver that baby. The facility has to have space and qualified personnel and agree to accept the transfer. The transferring hospital has to send all medical records related to the care that was delivered, and the patient has to be transferred in appropriate modalities, right? So the appropriate level of transport, the right ambulance, the right care facility. All of those are, I think, bread and butter to us. But the reason that they are really important to review is that they reinforce how many ways an EMTALA violation could occur in a world where we're now thinking of new kinds of patients to care for in new environments. So I'm going to leave that there, just to kind of start our baseline conversation of what is EMTALA. A lot of us think about this more than any general American. I ask lots of people, have you heard of EMTALA? And until the Supreme Court hears this case at the end of April, they will still not have heard of EMTALA. But it's up to us to start talking about it because it's turning into real national news.
This law has been in place for 38 years. It's the duration for any of us. I mean, the three of us who have practiced, although clearly we have colleagues that practiced before this law, but this has been the letter of the land that we have practiced under. Nothing has really been different for us, but now we are approaching what could possibly be a difference. But let's go back to 1985. What was the situation at that time that necessitated this type of a law to be passed?
You have to consider the economics. Prior to 1980, private hospitals often charged patients on their ability to pay, almost a sliding scale. And this allowed these large private hospitals to provide some charity care, meaning free or low-cost care to uninsured or underinsured patients. In 1983, excuse me, Medicare limits were placed on how much hospitals could be reimbursed for certain diagnoses. And as a result, hospitals were kind of unable to engage in this kind of sliding scale cost shifting to provide this free or low cost care for these uninsured or underinsured patients. Consequently, what we saw hospitals doing, and I'm mostly talking about these large private hospitals, is redirecting these patients from these private hospitals to public hospitals. And this was a practice that came to be known as patient dumping, in which hospitals transferred these patients, often involuntarily, or at least not with their knowledge of kind of why they were being transferred. And this resulted in delays in treatment and care, often disproportionately affecting racial and ethnic minority patients. And of note, as Dr. Kass alluded to, some of these patients were pregnant women who were in active labor, who were being turned away because of their insurance status. So as a result, EMTALA was passed by Congress as part of the Omnibus Bill in 1986, and it remains law today.
How has EMTALA impacted EM and hospitals over the last 4 decades?
EM was recognized as a specialty in 1979. So the majority of EM physicians who are clinically practicing today have only clinically practiced in a world where EMTALA applies and we understand its protections. EMTALA's enduring legacy is that uninsured and underinsured patients are given access to medical care that otherwise might be delayed or denied. You know, it holds up our ethos of any patient, any problem, anytime. And it's our bedrock law. And indeed, it's the reason many of us went into emergency medicine. It was to help any patient we could in any way we could. I think it's important to understand EMTALA is not without flaws. You know, it's an unfunded mandate. You know, and there are some arguments, and the economics and the data back this up, that it has placed a financial burden on hospitals. If you look at the numbers before, the 5 years before EMTALA versus the 5 years after EMTALA, there was a surge in emergency department visits post EMTALA, 85 million before EMTALA, 115 million in the 5 years after EMTALA. You know, and there have been arguments made that there's also a surge in ED utilization for non-emergency medical complaints. But both of these issues are very multifactorial, and it's not just EMTALA, but we have to understand that EMTALA is implicated in these decisions.
All right, so that gives us a little bit of the broad scope, but let's take it a little bit case by case and give some examples of EMTALA violations, because I hear this kind of bandied about. I hear it thrown around. Oh, that's an EMTALA violation. I'm not sure that we really understand exactly what that means. So let's get some examples of what it means.
Yeah, so just to have an idea of the context, about 4 to 5% of hospitals are cited for EMTALA violations annually. And it's important to note for us as physicians, both our hospital is fine, but we as individual physicians can also be liable and under EMTALA. And these are hefty fines up to, I think it's $119,000 is the limit. So the majority of these hospitals where we are finding these EMTALA violations are large for-profit urban hospitals. And prior to DOPS, studies have shown that the majority of these violations were for failure to provide a medical screening exam, so EMTALA's first requirement. But post-DOPS, what we've been seeing and kind of why we're here today is to talk about EMTALA violations with regards to pregnant patients with complications. Keep in mind that pregnant patients with complications are the 5th most common reason for an emergency department visit. And what is happening is these patients are being turned away if the stabilizing treatment requires termination of that pregnancy. An example being ectopic pregnancy or preterm premature rupture of membranes. And we have some very specific examples that we've probably, if you've been following this at all, you've probably heard about them in the news. For example, in February of 2023, an Oklahoma woman presented to an ED with a malignant molar pregnancy. She was told to wait in the parking lot until she decompensated. In December of 2022, a Florida woman presented to the hospital with PPROM. She was denied termination of her pregnancy from the emergency department. She actually went home, delivered the fetus out of the hospital, and later came back, required an emergency hysterectomy and ICU level care. And then the one that got the most media attention, which we're probably familiar with, is the case of Kate Cox in Texas just last December. Her fetus was diagnosed with trisomy 18 and she was denied an abortion. And this worked its way through the courts. And ultimately, she had to travel out of state when she was 20 weeks pregnant to save her life. And, you know, we can talk about these as isolated cases, but it's important to understand the consequences are dire. Women who do not receive these life-saving abortions can have severe sepsis requiring limb amputation, uncontrollable uterine hemorrhage requiring hysterectomy, kidney failure requiring dialysis, hypoxic brain injury, or permanent fertility loss.
These are some incredible examples of recent issues, and we're going to come back to those recent issues because I think that really is at the forefront here. But let's take it back to the individual physician. As frontline physicians, which we all are in the emergency department, we are going to be at the center of this. So if I'm working and I see something that sure looks like a violation to me, what am I actually supposed to do?
So there are numerous places on the CMS website, and I would encourage everyone out there to get really familiar with the federal resources that exist. There's actually a website called reproductiverights.gov, and in that it actually has the patient's right to emergency care. In there actually is a review of EMTALA, but also on the CMS website, which is cms.gov. It literally shows you how to file an EMTALA complaint. And one of the things that Monica just said, I think is really important. Anybody can file an EMTALA complaint. It can be a patient, it can be a family member, it can be a provider, it can be anonymous. You know, I've spoken to other EM docs who have really worried about these violations occurring in their community and were worried about retribution, about whether or not they would get fired or have penalties. And all EMTALA complaints can be filed anonymously. You submit the complaint through your state Department of Health, through your state agency. And that state agency then does an investigation and they communicate with the federal government to determine if a violation occurred. Many of the cases that Monica just talked about have gone through the investigations process and were found to be EMTALA violations. And then CMS comes down to the hospital or the provider, but usually the hospital, and actually penalizes the hospital with a fiscal penalty with the knowledge that a second or third violation could actually remove all Medicare funding to the hospital. So the aggregate number of violations are serious to hospitals, and it's one of the reasons that hospitals take them so seriously.
This is really important because I think often we put CMS as kind of an enemy to our care. This is a place where CMS is really trying to protect the individual physician as well as obviously protecting patients, right? This helps to protect us when we know the right thing to do. We know what should be happening, but somebody is making it hard for us to do the thing or virtually impossible to do the thing that is right for the patient. CMS is actually stepping in and helping the individual physician. Dara, that is not a situation we're used to. We're used to
No.
CMS coming in and telling us, you're not washing. Well, I know it's JCO, but it comes
Right.
from CMS. You're not doing your sepsis bundle. You're not doing your stroke bundle. You're not washing your hands. This is different. This is a place where they are helping us.
And look, I think that's something that just came out of working in the federal government next to my regional CMS officers with a lot of people in the DC CMS office. We don't realize how many ways they want to improve patient care and also are partners to us in actually getting that done. And also they cannot do their job if we don't bring them cases, right? So whether it's a civil rights violation or it's an EMTALA violation, it is our obligation to flag for CMS the kind of cases that we know need to be addressed. And if we're too nervous to flag them, what does that mean for our patients? So I want to put a pin in to say to our fellow providers and anyone listening, if you see something, say something. Flag it for CMS and let them do their job, even if you flag it anonymously.
We've got a lot of background here. We've talked about the law. We talked about how it's supposed to function. We do need to now jump forward to where we are right now. This is the law of the land for 40 years. Now there's a threat to it coming out of both Texas and Idaho. And before we get to those specific states, we do have to start with Dobbs versus Jackson. Monica, you mentioned Dobbs before. The case in 2022, which held that the U.S. Constitution doesn't have to confer a right to abortion, essentially overturning the Roe v. Wade ruling and making abortion law the purview of the state and not the federal government. With that as background, let's jump into those Idaho and Texas cases and see how this affects both reproductive health issues, but also the EMTALA law.
Idaho and Texas, and frankly, a handful of 14 states in the country, they have these abortion bans. And what happens is these abortion bans often do not provide exceptions for care of a pregnant woman who's in life-threatening situations. And if they do, it's often not clear what constitutes a medical emergency, what constitutes a life-saving abortion. So with regards to Idaho and Texas cases, they specifically ask the question, what happens when abortion is required or is life-saving? And I'm talking about very clear life-saving abortions in the case of PPROM, molar pregnancy, ectopic pregnancy. Idaho passed a near total abortion ban in 2020, and this was pre-Dobbs, and it was one of those trigger laws that was scheduled to take effect. It anticipated Dobbs coming. And Idaho's law does have limited exception for ectopic pregnancy, molar pregnancy, pregnancy as a result of rape or incest, or life-saving abortion for the mother. So DOJ came in right before the law took effect and sued, alleging the state of Idaho violated EMTALA by enforcing their abortion law. And a federal district court found for the DOJ. The state of Idaho appealed that to the Ninth Circuit, and a panel of 3 Ninth Circuit judges, all Trump appointees, reversed that decision. That was appealed by DOJ, and then the entire Ninth Circuit, once again sided with DOJ, blocked Idaho from enforcing their abortion ban in medical emergencies. Idaho filed an emergency appeal with the Supreme Court, and that is the case they will be hearing next month on April 24th. Important to note, in the interim, Idaho's abortion law stands. So Idaho physicians, emergency physicians, are practicing under this law. Texas law also looks at the clash of state abortion bans with the protection of EMTALA. And in that case, the Fifth Circuit found for the state of Texas and allowed Texas's abortion ban to stand. And this is a near total ban with only exceptions to save the life of the pregnant patient, prevent substantial impairment of major bodily function of a pregnant patient. But again, there's a lot of confusion and it's not really well iterated in the law. Indeed, Texas just declined to even give its physicians further guidance in what that exactly means. Crazy.
And yeah, I'm shaking my head here, but this is at the heart of the piece that you guys wrote with Esther Chu for MedPage Today back in March. We'll have a link to that in the show notes if people haven't seen it. The cases in Idaho and Texas, like you said, have now made their way to the Supreme Court. We're going to see those cases in the next couple of weeks. What's at stake here?
So, okay. So this is where I get a little fiery. Like if people could see us here, you can see started like the steam.
We're not going to have the video. We're not going to have the video available. There is steam coming out of ears. There is fire on the side of her head.
So, and the reason I say, like, I spent a lot of time talking to lawyers, like lawyers that do a lot of podcasting about the Supreme Court and explaining to them what we actually do, right? And why what we do matters. I mean, the amount of places and times that people are invoking emergency care and emergency doctors without any of us being at the table right now is amazing. I know we're recording this the week that they listened to the mifepristone case, which is the abortion pill case in front of the Supreme Court. And the entire case was rooted in emergency care of patients who have taken mifepristone. And as emergency providers, we know how ridiculous the entire foundation of that case is, because we've been taking care of patients who have pregnancy loss forever without, judgment, without questioning of how that pregnancy loss occurred. And that decision making, that context is actually what's at stake here. So what's happening? So right now, Idaho and Texas and all the states that have exceptions that are limited to the life of the mother are basically saying, if the life of the mother is at stake and you can determine definitively that someone would die without your intervention, we're going to let you go. But if it's not 100% sure that somebody would die without your intervention, right? And I can go on about cases that we deliver, that care that we deliver in the ER, where we're doing about health of the mother. We spend all of our time preventing bad things from happening to people, right? This is where we're getting real, right? We spend all of our time looking around the corner for badness and saying this person looks like somebody that's going to go south. And we are going to stop that, because we know that pulling somebody back from the verge of death is a lot harder than preventing that person from getting to that verge in the first place. These laws say at the verge of death, all right, we gotcha. We're not going to prosecute you, right? We're not going to remove the protection that EMTALA provides because you are clearly in an emergency. Somebody's blood pressure is 40 over nothing and their heart rate is, now also 22, right? They're hemorrhaging. All right, we got this. You can take care of them. But what does it look like to take care of somebody whose ectopic pregnancy is not viewable on the ultrasound, but their beta is rising, right? What does it look like to take care of somebody whose membranes have ruptured at 18 weeks, but they are not septic? Like, is there any other outcome to us except for the ultimate treatment that they need? But does the law protect you from giving that treatment now? What these cases say is that Idaho and Texas and all these states say, no, not yet. You emergency providers, you emergency physicians should not intervene yet, because that's health. That's not a definitive life-threatening condition. Our law stands that unless the person would absolutely die without that intervention, well, you don't have EMTALA protection. And when I reiterate that it is we think of EMTALA often as like a burden on us, right? I'm threatening somebody with EMTALA. I'm trying to transfer somebody from one hospital to the other because I don't have an ophthalmologist that will answer my phone call, right? EMTALA for us has been often like this thing that hangs over our head because we're trying to do the best we can for our patients. And it turns out EMTALA was protecting us as providers, right? It was saying to us as emergency physicians, you should do what you can for every patient that walks in that room. And if you do that, that is all we're asking of you. And that's what the federal government is reiterating here. They're saying to us as doctors, the DOJ, that you should continue to do what you do well, right? We are the DOJ, we are the administration, we are lawyers. We don't know what you do. We just are grateful that you're doing it, And instead, attorneys general in other states are saying, actually, we might want the opportunity to second guess what you do. And to me, that's what's at stake here. It's the idea that prosecutors could judge us not for medical malpractice, but for criminalization because we did the right thing, or we waited too long because we were afraid that if we did the right thing, we would go to jail.
This is kind of like the idea of the patient has myocardial ischemia. They've got T-wave inversions. They've got a little bit of a positive troponin, but it's not an infarction yet. So we can wait. And I think we all know that that's ridiculous. And obviously I'm carrying it to an extreme. but not that far of an extreme. And you mentioned that you can provide the care without penalty if the patient's life is at threat. But what about loss of fertility? That doesn't really seem to be covered in this. And we know that sometimes the complications that we see is not that the patient dies, but that they get the hysterectomy. And that's the loss of fertility.
I mean, even in ectopic pregnancy, right? One of the kinds of cases we're talking about a lot is the delay in diagnosis of ectopic pregnancy, right? So somebody has a rising beta, they don't have a visualized ectopic pregnancy in the tube, right? Or certainly extra kind of uterine. So we decide as a shared decision, will we give methotrexate now versus wait? And we know that if you wait and then 2-3 days from now, you see an ectopic pregnancy with a heartbeat in a tube, the treatment's different. And when you talk about consequences to patients and loss of future fertility, waiting to treat an ectopic pregnancy until I, as a physician, can prove that I'm treating an ectopic pregnancy so that I stay out of jail may have life-altering consequences for my patient. And none of those decisions had anything to do with what the patient wanted or what I knew how to do.
And the burden there is to prove without a shadow of a doubt, because we know that if the beta is rising, even if I don't see an ectopic pregnancy, that's most likely what we're dealing with. That's why we do the things that we do. This is saying, no, that's not enough. It's got to be 100%. There can't be any real allowance for, I could be wrong. There's a 5% chance that I'm incorrect, but there's a 95% chance that I'm doing the right thing.
And that's why it's important to protect us to do what we do, right? Like, I think that, again, the foundation of this is that we are emergency physicians. Look, collectively, we've been doing this for over almost 50 years between the three of us, right? And I think that's because I've been doing this longer than the two of you, which makes me sad. But, I'm still scared if I see a patient who is unstable in front of me, who I know I need to intervene, because if I don't do my job right, something bad could happen to them, right? That still gets my heart rate up. I don't think in my practice about, well, also the attorney general of my state could then come after me for the decision I make, even if the patient lives. Like, how absurd are we sitting here talking about the idea that delivering appropriate medical care to a patient to save their life could put me at criminal risk, and that attorneys general in states like Idaho and Texas are saying, yes, we need the authority to prosecute you for something that you do in an emergency. That is what they're standing up and saying in front of the Supreme Court.
Let's bring it back a little bit. I think that this is implicit in the discussion, but let's make sure that we are very clear here. Why does the federal government want to reinforce EMTALA in this situation? And why is Idaho or Texas taking a stand?
Yeah, so the federal government doesn't have a lot of places where they can say like a supremacy, right? So that federal law is supreme over state law when it comes to reproductive rights right now. This is one of the areas that they can, right? So EMTALA as a federal law, historically, and we know what the word precedent means right now to the Supreme Court, but historically, federal law has superseded state law when it comes to legislation that was passed, and EMTALA was passed into law in 1986. That is what the federal government is saying. It's saying our protection for every state in the United States. So every American who lives in every state, every person who walks across a state in the United States deserves the same protection when they go to an emergency department. And the attorneys general in certain states are saying, actually, your federal protection does not live here. Our state laws that we have passed through our state legislature, or were zombie laws, and they were triggered when the Dobbs decision came down, they actually prevail here. And I think that just to kind of bring this back to the focus of what people need to listen to, and I really, really encourage, I know a lot of people out there listening to this are not used to thinking about the Supreme Court or state legislation or what's happening in the White House or at the DOJ. They just want to do their jobs. We go to work, we have a hard job. We are underappreciated by society right now. Half of us are getting underpaid and working with less resources than we ever did before. I really encourage you, if you can, to listen to the Supreme Court oral arguments when this comes down at the end of April. Even if you can't do it in real time, these are recorded and you can listen to it after the fact on supremecourt.gov. You will hear justices and attorneys talk about us and our job. and the work we do every single day. And you need to think about what their perception of what we should do and how we should do our job will inform future policy and our autonomy. Many, many of us come to work in the ER specifically, like Monica said, because every patient, every day, anytime, no matter the ability to pay, as long as I know how to take care of you, you're going to get the care you deserve. That is exactly what's at the heart of this case, is that attorneys general and state legislators are saying, actually, no, not any patient, anytime, not all the care you know how to give, just the care we think you're allowed to give under our new law that restricts certain aspects of healthcare for certain patients.
Monica, I want to hear your thoughts on this too. Should the court rule that EMTALA should be interpreted at a state level instead of at a federal level? How does this impact what we do in the emergency department?
Well, it's tricky, right? Because as Dr. Kass alluded to, we have the supremacy clause. And the supremacy clause is that federal law trumps state law. That is in the Constitution of the United States. That's not changing. But the issue here is kind of to think about what we know the court is and the composition of the court right now and how that's going to play out. We know two things about the court. Right now, we know that the court is dominated by conservative justices. Conservative ideology favors states' rights over federal rights. And so they're already leaning into that idea that maybe this should be a state interpretation. And the other thing, and I think this is important, and this really links into what Dr. Kass was saying a little bit earlier about our autonomy. We have to think about emergency physicians and all physicians in the practice of medicine about how the court has come at us in terms of our role as physicians. If you go back to Roe and you think about the language of Roe, abortion is a decision between a physician, a patient, and her physician. Done. You go through time and you go through Casey and all these other abortion cases, and you see kind of a little bit of evolution of how, and I would actually argue it's a de-evolution of how the court kind of respects our autonomy. And you fast forward all the way to Dobbs, and you have the term physician isn't even used that often. They call us abortionists, and this is true in abortion law, but it's also true if you look at some of the arguments around the Affordable Care Act. And so we know that we're already dealing with a Supreme Court legal landscape where they're taking that away from us. And so as physicians, it's just so important we click into this and understand what's at stake. Our autonomy as physicians to care for our patients is going to go away. And that's going to radically change the practice of medicine, especially emergency medicine.
I think that's the most important thought to leave everybody with, because I think there are going to be people who are going to say, this doesn't apply to me. It doesn't apply to where I work. It doesn't apply to what I do. But at the heart of it, it does. It does apply because it is challenging the autonomy of a physician to take care of a patient. And in an emergency setting, it's challenging our ability to recognize and determine what is an emergency and what care the patient should receive. The development of emergency medicine over the last 50 years, our defining ourselves in our specialty has radically changed the provision of emergency care in this country. And this is going to be a step back. By taking autonomy away from the individual physician, from taking autonomy away from the physician and the patient together to make decisions of their care, is a massive, massive step back in treatment. And this is going to affect not just reproductive health, but it's going to affect a ton of things that we do, and we have to see that. And this is the time for us to start to get involved. And you guys know this is not the area that I have been involved in, but there are lots of people out there who listen, who are on the verge, who are thinking about being more involved in this space. This is the time. This is the time to step in, to lean into this, to become more involved. We're going to have some great resources for people. I'm not going to be giving out email address, but I'll tell you that Dara and Monica would be happy to help people figuring out their way into this area, to figure out how to get more involved, where to get more involved, how we can really do a better job. And at the heart of it, it is both protecting our roles as physicians and, most importantly, protecting our patients.
I agree. And I think the last thing I will say as I ask to anyone listening is just pay attention to the next month and a half of what people are talking about. This case will be heard in April, and then the decision will come down probably the end of June, amongst a lot of other decisions. But it is a time for us as emergency physicians to tell people what we do, right? Tell your family what you do. Talk about it in your community. You don't have to do a podcast or go on TV or write an op-ed. You don't have to get involved in a campaign. You don't have to do anything more than you feel comfortable with. But at its core, it's important for us to remind our community and our friends, at PTA or wherever you are, that, if you want to get the care in an emergency room when you need it, please let us do our jobs.